Dr. Whitlatch speak. And then I just wanted to say that Enloe Medical Center is the partner that sponsors these virtual grand rounds and provides the continuing medical education. So thank you for Jack and Bailey for being here, and no new updates from them. So we'll just go in with Dr. Whitlatch to the presentation. Thanks so much for joining us today.
Thank you. Thanks for having me today. So I'm Nicole Whitlatch. I'm a hematologist oncologist here. I've been at Enloe Cancer Center for about, I guess, just over 10 years, almost 11 years at this point. And I've had the opportunity to focus on treating just breast cancer for the last 6 years. So today I'll provide an update in breast cancer. It's a big topic, of course. So I have on this first slide here, I think, let's see if it'll progress here, kind of an outline. So we'll talk about current breast cancer incidence and risk factors. I'll touch on screening for breast cancer. We'll talk about the different types of breast cancer, because it's pretty interesting in that breast cancer really is not one disease. And then I'll touch on how a medical oncologist such as myself will approach treatment to a newly diagnosed breast cancer. So globally, breast cancer is the most common type of cancer in women. It's also the leading cause of cancer death in women. In the United States, it's the most common cancer and the second most common cause of cancer-related deaths. So here's a figure from a recent article that kind of lists the incidence of different cancers. You can see breast is the most common in the last year, with an incidence of over 280,000 women diagnosed, 30% of all female cancer diagnoses. Whereas here, when you see the leading causes of death, lung cancer is actually the leading cause of death in women, followed by breast cancer. This is a graph from the same article, kind of trending the incidence of breast cancer over time. And you can see that the breast cancer incidence rate has continued to increase over time, which the authors in this article feel is at least in part attributed to declines in fertility and increasing incidence of postmenopausal obesity. In terms of breast cancer survival, the good news is that even though breast cancer incidence is quite high, that women are surviving, and the 5-year survival of breast cancer is high. It's typically about 90%, and highest survival rate of many of the cancers that are diagnosed. Here's just a complicated graph, but it's showing how female breast cancer, you can see the 5-year survival rates for localized breast cancer, so early stage, is upwards of 99%. And this is impacted, unfortunately, by race. We see differences in terms of survival, with Black race predicting slightly lower risk of survival over 5 years. And some of that difference may be due to socioeconomic factors, or it can also be due to just, we do know that unfortunately, African-American women in particular present with more riskier types of breast cancer, like triple negative, and we'll talk about that. So what are the risk factors for breast cancer? So increasing age is probably the biggest one, along with being a female. Elevated body mass index is a risk factor in postmenopausal women, but really does not seem to be a risk factor in premenopausal women. Also, the combined use of estrogen and progesterone for hormone replacement therapy has been associated with development of breast cancer. Interestingly, an update of the Women's Health Initiative study in the last year showed that estrogen use alone may actually be protective against breast cancer, although it's not currently being advised to use it for that reason. But I think it kind of contradicts what we'd had thought over many years, so that's interesting. In terms of risk factors, specific ones, we talked about increasing age. So here you can see that from birth to death, the lifetime risk of developing breast cancer, there's that 1 in 8 statistic that we all hear. So about 12.9% for any woman to develop breast cancer in her lifetime. That risk doubles when you're 70 and older, and then is less so in premenopausal women. In terms of other risk factors, we talked about female sex. So we talked about over 280,000 women are diagnosed each year with breast cancer, whereas there are less than 3,000 cases in men. So in men, it's 0.5% of all cancer diagnoses. As such, in the clinic, whenever we see a male patient with breast cancer, our guidelines indicate that we should send them for genetic testing to look for some genetic predisposition given the rarity of this. Up to 14% of men with breast cancer will have a BRCA2 mutation. BRCA1 mutations occur rarely, more often in men with Ashkenazi Jewish ancestry. So elevated body mass index is a clear risk factor for postmenopausal breast cancer. And we think it may be due to higher levels of circulating estrogen resulting from peripheral conversion of estrogen from steroid precursors in fatty tissue. Conversely, there's an inverse relationship between body mass and breast cancer incidence in younger women, premenopausal women, and it's unclear why that's the case. Combined estrogen and progesterone use is clearly a risk factor with a relative risk of 1.26 for the general population. And as I touched on, the risk of breast cancer in women who've had a hysterectomy and take estrogen alone is actually lower than women who did not take estrogen. So it's really just combined hormone use that predisposes to breast cancer. Other risk factors include genetic predisposition, so having some type of inherited mutation, but this we think really only accounts for 5 to 10% of all breast cancers, although we're learning more about this all the time. We routinely will test women for a genetic predisposition when they present at a younger age, because as we said, developing breast cancer when you're premenopausal is pretty uncommon. So we want to look routinely in women who are under 50. We'll refer them for genetic testing. Definitely under 45, it's a guideline practice. Early onset of menses, later onset of menopause has been linked to breast cancer development. And increasing alcohol intake also leads to higher incidence of breast cancer. There seems to be a linear relationship, so the more you drink, the higher the risk. And most articles on this note that more than 5 drinks a week seems to be that cutoff point. Nulliparity is a risk factor for breast cancer, as is a strong family history in absence of a genetic predisposition. Just having multiple family members with breast cancer can increase an individual's risk of getting breast cancer. So screening is somewhat controversial. I'll show you in the next slide that the guidelines really vary based upon the clinical society. So it's a little confusing, I think, for some of our primary care docs and internists on how to approach this. But the National Cancer Comprehensive Network guidelines, which is what medical oncologists practice by, do recommend annual mammogram for women at average risk of developing breast cancer starting at the age of 40. For a woman who's had breast cancer or has high risk for breast cancer, that recommendation can change, and sometimes we incorporate breast MRI in these individuals. So this next slide is taken from Up to Date, and it just shows kind of how these different societies will have different recommendations in terms of frequency and age of onset of screening. But the American Cancer Society, for example, states typically annually starting at age 45, and then, but will individualize, up to age 44, what they'd advocate based on a patient's history. And then American College of Physicians says every 2 years, individualize between 40 and 49, and then definitely screen age 50 and up. So you can see that there's a lot of variation here, but this is what we practice by the national, what we call NCCN guidelines, which says once a year, age 40 and up. And that's pretty much what I advise for all my patients with average risk. So what we do know is that early detection definitely saves lives. So I think it is important, regardless of which society you follow that you are recommending that your patients have breast cancer screening. So the next topic, moving on, would be types of breast cancer. Does anyone have any questions about what we've talked about so far in terms of screening or risk factors, or do we want to hold questions to the end, Christy? Or
it's up to you. If anybody wants to ask a question, just unmute yourself.
Yeah, we can just do that. And you guys can feel free. We're such a small group. You can feel free to stop me and ask me if things come up along the way as well. So in terms of types of breast cancers, all new breast cancers are tested for 3 proteins: estrogen receptor, progesterone receptor, and human epidermal growth factor receptor. And these 3 things define what we call the phenotype of breast cancer and help to define, how we're going to approach treatment for the patient. So 80% of what I see is hormone positive breast cancer, and that's defined as being estrogen and or progesterone positive. This type of breast cancer tends to have the best prognosis. Estrogen receptor being positive is more important than progesterone receptor being positive. The ER status is the main driver of prognosis. That being said, when tumors are progesterone negative, they have a slightly worse prognosis than if they were both ER/PR positive. And then HER2 positive breast cancer represents about 1/4 of breast cancer. This tends to be an aggressive type of breast cancer. In the clinic, I'll see women who had a normal mammogram and then 6 months or years later present with a palpable mass. That's not uncommon with this type of breast cancer. So it grows fast in between mammograms sometimes. And it used to be associated with a worse prognosis, but now we have what we call HER2-directed therapy antibodies called Herceptin and Perjeta that target the HER2 receptor. And so now these patients are doing very well and have often a very good prognosis. And then the dreaded cancer type with what I do is what we call triple negative, ER, PR, and HER2 negative. This is fortunately not a large amount of breast cancer, about 13 to 20%. It does vary by race, as we touched on. It's definitely an aggressive type and has the worst prognosis of all the breast cancer types. And the trouble that we've had with this cancer up until recently is that we had no target. Like, we have the HER2 targeted treatment, we have hormone blocking therapy for the ER/PR positive. For triple negative, we haven't had a target up until recently, and now we're seeing good results with therapy that includes immunotherapy in this cancer subset along with chemotherapy. Breast cancer types have also been defined as what we call these molecular subsets. And this is more kind of a lab kind of characterization of a tumor based upon its genomic expression. But we see this routinely in the literature. Tumors are referred to as luminal A or B, and those are typically hormone positive, HER2 enriched, which are not all HER2 positive, but are often hormone negative, and then basal type, which is primarily triple negative. So this just shows how these can be prognostic as well. So the luminal subtypes tend to have a good prognosis, whereas basal-like and HER2 high tend to have a poorer prognosis. In terms of approach to treatment, these molecular subtypes, which we test for by this PAM50 assay, provide prognostic information, but we're not routinely using them in clinical practice. It's really just the ER, PR, HER2 that determines treatment. So the last focus of the talk will be on approach to treatment. So the widespread use of what we call adjuvant, which is post-operative treatment for breast cancer, has dramatically reduced mortality from breast cancer since the 1970s. And so why we're seeing women who get diagnosed with breast cancer are doing well. So how I explain my role to patients in the clinic is I explain, the surgeon and the radiation oncologist are all about local control, removing the tumor, staging it. Radiation will prevent a local recurrence of breast cancer. And our job in medical oncology is to offer whole body, or what we call systemic treatments, that in the setting of early stage breast cancer, so stage 1, 2, and 3, our treatments prevent recurrence of breast cancer in either breast or at a distant site, preventing metastatic breast cancer from developing. When I have a patient with metastatic breast cancer, I explain my job is to provide these same treatments with a goal to prolong survival and improve quality of life by reducing cancer-related symptoms. But at the same time, you know, with all of these treatments, not just metastatic breast cancer, but our goal is to limit toxicity and minimize side effects from the treatments that we're offering to our patients. There was a new staging system that came out in 2018 for breast cancer, which is neat in that it doesn't just incorporate what we call TNM, which is tumor size, nodal status, presence or absence of metastases, but it also includes the addition of ER, PR, and HER2 into a tumor staging. And so this is kind of the old anatomic staging where, you know, mostly stage 1 breast cancer is lymph node negative or micrometastatic lymph nodes. Stage 2 is typically lymph node positive or very large tumors. And then stage 3 is when you have multiple positive lymph nodes, 4 or more. But the newer staging system is actually like 10 times the size of this because it alters the stage based on ER, PR, and HER2. So before, for example, when a tumor was N1, it was stage 2. Now, if a tumor is N1 and ER positive, HER2 positive, it'll often be a 1B. So we're seeing better prognosis with better treatment, and that's now reflecting in our staging. So what I explained to patients about my job too is that I have 2 tools to treat their breast cancer. And essentially, I have hormone blocking therapy, which are medications that drop estrogen and progesterone for hormone positive breast cancer. That's what we term endocrine therapy is the other name for that. And often we'll combine the hormone blocking therapy with these newer medications called CDK4/6 inhibitors that inhibit the cell cycle and enhance the activity of the hormone blocking medications. And then the other tool that I have, so to speak, is chemotherapy, which we combine now often with targeted treatments. I mentioned immunotherapy in triple negative breast cancer, and then HER2 targeted treatments are utilized with chemotherapy for HER2 positive breast cancer. So for this next part, I thought I'd focus on the different types of breast cancer, the 3 main types, and how we approach treatment. So like in the primary care setting, you'll probably see a lot of our patients who have hormone positive breast cancer on these hormone blocking pills. And it's, like I said, we call it adjuvant endocrine therapy. And it's the mainstay of treatment for hormone positive breast cancer that's HER2 negative. This type of breast cancer, again, is the most common. And often these patients do not need or won't benefit as well from chemotherapy. Because the hormone blocking therapy provides such a big benefit, a 50% reduction in recurrence of breast cancer, including both local recurrences and distant recurrences. So we have 2 types of pills essentially that, you know, will treat this cancer. One is called an aromatase inhibitor, which is preferred in postmenopausal women. It only works in postmenopausal women, but it also works better than tamoxifen in postmenopausal women. And then we utilize tamoxifen in premenopausal women. And the caveat here is if a premenopausal woman has a more advanced stage breast cancer, then we'll be a little more aggressive and we'll actually put them into menopause with what we call ovarian suppression and use the aromatase inhibitor. So this is just a diagram showing how the 2 pills work a little differently. So tamoxifen is what we refer to as a selective estrogen receptor modulator. What that means is it just impacts estrogen binding. So here you can see tamoxifen blocks the binding of estrogen to its receptor. Whereas aromatase inhibitors, what they do is they block this enzyme aromatase located in these different tissues. And in doing so, they reduce the production of estrone and estradiol from these other hormones. So if you can imagine in a premenopausal woman who's still ovulating and has active ovarian function, this really isn't going to do much because they're making a ton of estrogen from their ovaries. So blocking peripheral production of estrogen won't do much, and that's why they don't work. But tamoxifen works in these premenopausal women because it's binding estrogen, it's blocking binding of estrogen to its active site. So in terms of how long women stay on treatment, ASCO, which is the American Society of Clinical Oncology, just did a practice guideline update in February of 2019 about how long we should be continuing these medications. So basically, the current recommendation is minimum of 5 years, maximum of 10 years. And typically we'll go out to 10 years in a patient who's higher risk, meaning that'll often be younger patients, and patients who have more advanced breast cancer, like positive lymph nodes, stage 2 and 3. And I mentioned that most of the patients with hormone positive breast cancer won't need chemotherapy because of the benefit of the hormone blocking therapy. So how do we figure this out in the clinic, whether or not they need it? So we have traditional, what we call the pathologic prognostic factors that we look at, and that includes lymph nodes being involved, high grade, or maybe weak ER expression where we're worried they won't respond well to the hormone blocking treatment, or it won't work as well. Now we have these genomic assays that you guys may have heard about. One that we routinely use is called an oncotype that's sent on the patient's tumor. We use these for stage 1 and 2 tumors, essentially any tumor that's 6 millimeters or greater. We can use this assay to tell us if there is a benefit to chemotherapy. And this assay was just approved in December of 2020 for women who have lymph node positive tumors, whereas prior to December 2020, we were offering all of these patients chemotherapy and endocrine therapy. Now, if they have limited positive lymph nodes, we can send this assay to determine if they would benefit from chemotherapy or not. And so this is the assay. It's called the Oncotype DX, and this is directly from the Genomic Health website who produced this assay. And so, it talks about how they help with decisions in early stage breast cancer, and less than 10% of patients with hormone positive HER2 negative breast cancer will need chemotherapy. And this test can help define who those patients are. So the test provides what's called a recurrence score, and it comes back between 0 and 100. And the recurrence score is based upon the genomic expression of 16 different genes that have been shown to define chemotherapy benefit. So bottom line, if a score is greater than 25, so 26 to 100, we know there's some benefit from chemotherapy and we should be offering it to our patients. And then as a subset, this benefit is further defined by a patient's menopausal status, meaning lower scores actually indicate that there may be some chemotherapy benefit in premenopausal women. So here's an example of what we'll get from this oncotype. Gives you 3 pieces of data, the recurrence score 0 to 100, and then it tells you this information, which is specifically the risk of a recurrence, and this is a distant or metastatic recurrence with the hormone blocking therapy alone. So aromatase inhibitor and tamoxifen, either one. It tells you what the risk of recurrence is, assuming the patient takes that hormone blocking therapy. And then it tells you the absolute benefit of chemotherapy. So in this particular example, the recurrence score is high at 32. So we know there's a big benefit, greater than 15% of benefit from chemotherapy. So we'll offer chemotherapy in addition to the hormone blocking therapy to this patient. We also know that if the patient tells us, you know what, I don't want to do chemotherapy, what will that mean for me? Well, we can tell them if you don't take chemotherapy and you do the hormone blocking pills, you'll still have about a 20% chance over the next 9 years of developing metastatic breast cancer. So this is very helpful, I think, to patients, in addition to us as clinicians when we're making treatment decisions. And what I always explain to my patients is that this report assumes that a patient's, going through adequate local control, meaning this tells us nothing about benefits of surgery or radiation. it presumes that a patient will have the type of surgery that they need and radiation when appropriate. And then the last piece on this report that's of importance to our patients is that when patients are younger, and this is really premenopausal versus postmenopausal is what we think this is showing us, that we see a chemotherapy benefit start to occur when the recurrence score is 16, rather than for all comers, it's just at 26 and above. And so we'll see a small benefit up to 20, and then a bigger benefit for these younger patients starting at a recurrence score of 21. So in this setting, expert guidelines say we can offer patients chemotherapy if they're, of that age group and have this recurrence score, or we can be more aggressive in our hormone blocking therapy, because we think that some of the chemotherapy benefit seen here is due to suppressing ovarian function and making women postmenopausal from the chemotherapy. So this just kind of shows what I was just talking about women under 50 with lower recurrence scores. We may want to consider chemotherapy. There was these new drugs that came out about 5 years ago called the cyclin-dependent kinase inhibitors, or CDK is how we shorten them. These pills have really revolutionized the treatment, especially of metastatic breast cancer that's hormone positive, HER2 negative. You may have seen ads on TV. They have ads for Ibrance, Kisqali, and Verzenio, or the three of them. So what these drugs do is they inhibit the cell cycle. And basically when you inhibit CDK4/6, this leads to activation of the tumor suppressor gene RB, which causes cell cycle arrest. This is kind of a complicated diagram, but it shows how our hormone blocking therapy works along with the CDK4/6 inhibitors. When we inhibit the activity of cyclin D1, essentially what it leads to is there's no longer phosphorylation of this tumor suppressor RB. And so then RB can go ahead and stop transition and growth throughout the cell cycle. So I mentioned palbociclib is Ibrance, ribociclib is Kisqali, abemaciclib is Verzenio, and these are all approved in the metastatic setting, combined with an aromatase inhibitor, anti-estrogen therapy. And so we use this frontline in all of our metastatic patients that are hormone positive, HER2 negative. And it's become very rare for us to offer chemotherapy to metastatic hormone positive, HER2 negative breast cancers, because these drugs are working so well to improve survival and disease progression. There's now been promising data shown to us over the last year for using one of these drugs, abemaciclib, in the curative setting. So the basic principles with cancer are, when you see good response with a medication in the metastatic setting, you then do trials and pull it up into the curative setting to see if we'll see that same benefit. So Monarch E was published in the last year that randomly assigned over 5,000 patients to use this drug we routinely use in the metastatic setting with normal endocrine therapy or the endocrine therapy alone. And then they looked to see benefit. And so what we can see here is that the blue line is patients who got the abemaciclib with the standard postoperative 5 to 10 years of hormone blocking therapy. And the red line is the patients who just got the endocrine therapy. And there was a benefit when we added this drug. It was about 3.5% benefit. And so, that's not huge, but to some patients it's meaningful, especially if they're higher risk. And all these patients, I should say, were high risk. They were stage 2 and 3. And most of the events that were prevented by adding this drug were distant or metastatic recurrences. And so this drug is not yet FDA approved for a curative setting, but probably will be in the near future. So the last two things to talk on would be the last two types of breast cancer. So HER2 positive and triple negative breast cancer, as I mentioned, are more aggressive types than hormone positive. And most of these patients, unless they're really small lymph node negative tumors, so 5 millimeters or less, Most will require treatment to include chemotherapy. Unique to these two subtypes is these are the two breast cancers where we often will advise preoperative, what we call neoadjuvant chemotherapy. And that has now become the standard of care for either one of these tumors when they're 2 centimeters in size and or lymph node positive. So utilizing chemotherapy up front or neoadjuvant chemotherapy allows us to assess the tumor's response to treatment in real time. And our goal is that we obtain something called a pathologic complete response, or a path CR as we call it, which means the patient gets all their chemo, they go to surgery, and there's nothing left in the breast or lymph nodes at the time of surgery. Studies have consistently shown that path CR can correlate with survival. So that's our goal for our patients. And that's how a lot of these new drugs are studied, you know, looking for, in the neoadjuvant setting, looking for a response, looking for a path CR. Then at the time of surgery, if residual tumor is present, that allows us to do things in the postoperative setting that will improve disease-free survival and overall survival. For example, routinely with triple negative breast cancer, we'll give a chemotherapy called Xeloda in the postoperative setting if there's residual tumor. We now have FDA approval for a HER2 targeted drug called Kadcyla if there's residual disease in the breast after neoadjuvant treatment. HER2 positive breast cancer, the treatments have kind of exploded over the last few years, and we have multiple new medications that have been FDA approved, which has been pretty exciting in the clinic, just to have more options for our patients, both metastatic and early stage. So in April of 2020, there was approval for an oral HER2 drug called tucatinib. Deruxtecan was approved in December of 2019, and then margetuximab was approved this past December. And another great thing that we've seen is that with metastatic HER2 positive breast cancer, patients are now experiencing long-term survival. So we use this regimen frontline for metastatic HER2 positive breast cancer called the Cleopatra regimen, which is a combination of one chemo drug called docetaxel with 2 HER2 targeted treatments, these antibodies, Herceptin and Perjeta, that attack the HER2 protein. It's called the THP regimen. There was an update in March of 2020 of this regimen that revealed with 8 years of follow-up, 37% of patients with metastatic disease were living after getting this regimen. And the chemo is given typically for 6 months, and then patients continue on these HER2 targeted treatments, which have very limited side effects, and they'll stay on those during these 8 years of follow-up in this study. This is a complicated slide, but just showing how our HER2 targeted treatments work. So the human epidermal receptor has these 4 different proteins, and the Perjeta and Herceptin I was talking about are antibodies that attach to this extracellular domain of the protein and then block the proteins from dimerizing and then having these downstream effects. We also now have 4 different oral tyrosine kinase inhibitors that attack the HER2 protein. I mentioned tucatinib was recently FDA approved, and then block cell growth through these pathways. So lots of new treatments, and they can be placed at different parts in the treatment schema. And this is, I know, a very busy slide, but what it shows us is how it's become pretty complicated how we approach just HER2 positive breast cancer. And so these are all the drugs that we now have available to us to use. Up here, this is how we approach early stage, meaning less than 2 centimeters and lymph node negative. These patients routinely go to surgery first, and if surgery confirms stage 1, so node negative small tumors, then we treat them with a regimen of 1 chemo drug plus Herceptin for 12 weeks, and then they finish the antibody treatment for a year. Sometimes we go to surgery and we find more advanced disease. Our clinical staging isn't always 100% accurate, meaning our mammogram, ultrasound, breast MRI. So if that's the case and the patient has more advanced disease, then we provide typically 2 chemotherapy drugs with trastuzumab, which is Herceptin, pertuzumab, which is Perjeta. And patients will complete a full year of the antibody therapy, typically about 4.5 months of chemotherapy. And this same regimen is what we use when we're doing treatment up front for those bigger tumors and or lymph node positive tumors. We'll do neoadjuvant therapy with Herceptin and Perjeta. Then patients go to surgery. As I mentioned, if they have a path CR, meaning no tumor, then they complete a full year of antibody treatment. And then we consider one of these oral tyrosine kinase inhibitors, to complete another year of treatment. And there's some subtleties here. This is for hormone positive, HER2 positive breast cancer. If a patient has residual disease at the time of surgery, then we're talking about doing this. It's Kadcyla is the trade name for a full year. And then these two kind of pathways describe how we approach metastatic disease. This is that Cleopatra regimen I was talking about. And then this is second line, third line, and then fourth line. You can see we have all these options to offer our patients now in the clinic. If a patient has brain metastases, which unfortunately 50% of patients with HER2 positive breast cancer will develop brain metastases during their lifetime, then this recommendation changes a little bit because we now have approval for tucatinib, which crosses the blood-brain barrier and treats patients with brain metastases quite well. And then the last cancer type to talk about is triple negative breast cancer. Much like HER2 positive breast cancer, in a patient with triple negative breast cancer, we will advise neoadjuvant or preoperative chemotherapy in larger tumors, so 2 centimeters or greater, and or node positive. As of July, the standard of care has now become to offer these patients chemotherapy, but we add in immunotherapy as well to this regimen with pembrolizumab, which was approved based upon this study in July of this year. And then we've been utilizing immunotherapy with chemotherapy for triple negative metastatic breast cancer for the last few years, including atezolizumab and pembrolizumab. And so this is just a slide documenting what do these immunotherapy drugs do. So pembrolizumab, essentially what it does is it blocks the activity of PD-L1. So normally you'll have a tumor cell, you have your body's immune system, your T cells, that will recognize a tumor cell and kill it. And if we inhibit the action of PD-L1, it allows our body to fight off the tumor. And so that's just what this is showing, that blocking PD-L1 allows for our body's immune system, our T cells, to kill the tumor cell. This is just that keynote data that led to the approval of pembrolizumab this summer for triple negative breast cancer. It's looking at this pathologic complete response rate, and that can be defined different ways here. But the take-home message is that overall, there was a 13 to almost 15% improvement in the rates of having no tumor at the time of surgery when you add the immunotherapy to the chemotherapy. There was also an improvement in what we call event-free survival, blue line being pembrolizumab or immunotherapy plus chemotherapy, red being just the chemotherapy alone, so that patients did better in the post-operative setting in terms of event-free survival. And that's what led to its FDA approval, those two endpoints. In the metastatic setting, we also have approval as of April of 2021 for a newer drug for triple negative breast cancer called sacituzumab govitecan. And this can be used after progression on 2 or more therapies, including after progression on immunotherapy. So in summary, breast cancer is very common, but survival is increasing with time as we have implementation of better treatments. Early detection clearly saves lives by leading to earlier treatment with good long-term outcomes seen for many of our patients. And then the last few years has been an exciting time for breast cancer in that it's led to FDA approval of many new treatments for each of the breast cancer tumor subtypes. Thank you for listening.
Thank you, Dr. Whitlatch. Does anybody have questions?
No, it was great. Thank you.
Oh, you're welcome.
I think it's really remarkable how many different medications and classes of medications have really rapidly come to the forefront in breast cancer. What would you say for the next year or two that we can look forward to maybe seeing anything on the horizon?
Good question. Well, I think probably the biggest thing is this focus on de-escalation, of treatment that we're seeing, as you know, in many tumor subtypes, right? Trying to minimize side effects, limit chemotherapy when we can. And so I think a lot of those trials are going to be important, especially with HER2 positive breast cancer. There's currently a trial enrolling at Stanford with the kind of like the APT regimen, but it's weekly Taxol with Herceptin and Perjeta for stage 2 and 3 HER2 positive breast cancer. Because we had that ADAPT trial data from ASCO that showed good responses. And even there are some really good responses in the antibody only arm. So I think, that's something to look towards, less chemotherapy for HER2 positive. Other than that, I think we're not quite sure about how the cyclin DK4/6 in early stage disease is going to pan out, but some things, we're doing in clinic. Yeah, I think those are probably the biggest things.
Nicole?
Yeah.
This is a pretty simple question, but I think when you were showing the mammogram recommendations, is there a consensus now that you don't need to screen women beyond age 74? Is that what I saw?
Certain, can go back to that side, certain societies are saying that. NCCN, though, doesn't really give an age limit, as I recall.
Okay.
So, and that's what, as you know, we always follow. But a lot of societies are saying that. And yeah, let's look at that. And that's a tough thing that we see in the clinic, because there are a lot of us who will see, women who are in their 70s and 80s who haven't had screening, and then they present with a triple negative breast cancer.
Right.
And it puts us in a tough position, right? Because we don't want to have to give them chemotherapy, but we wind up in that setting. So yeah, if you look here, so greater than 70 years, do you keep going? And so NCCN just says, yes, you just keep screening. American College of Radiology says yes, but then these societies and Cancer Society too says to keep screening. And then it's really some of these societies up that recommend stopping at certain ages. But I think what it comes down to is, like, if you have a functional patient, who's healthy, we should be screening them without having an age barrier. If they're fit and they want to do screening, I think it makes good sense, because then we're left with a predicament if we haven't screened of women, in their late 70s, 80s. I've even had some women in their 90s over the last few months presenting with advanced breast cancer that is much harder to treat.
Right. And of course, there's always the issue of mammograms detecting tumors that are easy to treat through screening, whereas it misses the young woman or the older woman with the aggressive tumor. Right. Or at least that was often my experience. Yeah.
Yeah, like we said, those more aggressive tumors can pop up even in between mammograms.
Or have or just don't have the usual mammographic features.
Exactly.
The density, the calcifications, and so on.
Exactly. Yeah.
Thank you.
Yeah, thank you.
Does anybody else have questions? All right, well, I'm recording this, and it will be available on Butte-Glenn Medical Society's YouTube channel Just give me a couple of days to get that posted, and then we can share it more broadly. This is October, which is Breast Cancer Awareness Month. So thank you so much, Dr. Whitlatch, for sharing this. Definitely some big new updates that we want to be sure to share with everybody. So thank you for doing this.
You're welcome. Thank you for having me.
Okay. Have a great day, everybody.
You too. Bye-bye.
Thank you.